Okay. Jacqueline, take it away.
Okay, I have two cases to present this morning. Morning or good day, or good afternoon, good evening, everyone. The first case, the next slide, please.
Okay.
Okay, it's a 27-year-old para 3 gravida 4, presents with antepartum hemorrhage, and she was found to have a cervical lesion at 35 weeks. Okay. Biopsy was done and sent to us, and gross, just 5 pieces of white soft tissue received, and in aggregate, they measured 20 by 10, so not a lot of tissues received, but from that big mess. Microscopically, you see the normal ectocervix there. It looked benign to me, and then just underneath the ectocervix, we have these large tumor sheets of tissue. And somehow at low power, they do have that kind of um, starry sky appearance with all those small white vacuolated spaces. Yeah. The next slide. At lower power, you see that the cells some are forming nest as well. And I think in the other slides, you also see some trabeculae formation. The next slide, please. And the cells themselves are more like hyperchromatic. Some show, like some of you mentioned, nuclear molding, and there's a lot of mitosis seen. Next slide, please. Next. Thank you. So there was no transformation zone or endos cervical tissue seen in all these samples. Next. Yeah. And then again, like I mentioned, they seem to also form trabeculae there. Next. And they also have this propensity to surround these blood vessels as well. Okay, next slide. It's just similar picture. Just this hyperchromatic cells, round to oval cells. Next. And the reason why I'm pointing out trabeculae, because my differential is based on what I saw with this formation of these like columns or bars or that. But a lot of mitosis. Next. I think some of you mentioned that you also saw some focal salt and pepper type nuclear chromatin, which I reviewed and I agree as well. Next. I'm not sure whether that's is that a blood vessel with the tumor in it, or it's just extension of the tumor. That one there, yes. Yeah. Next. This just the same type of cells again. Next. Yeah. A lot of mitosis. So this is actually pending reporting. I just wanted to review with all of you before I reported this this case. Next. So my differentials were poorly differentiated endocervical adenocarcinoma. I spoke to the ONG team, and they mentioned that it's just it seems to arise not from the uterus, but from the cervical region. That's why they mentioned they think it's more from the arising from the cervix than from the uterus. And I gave those differentials there. Small cell neuroendocrine because of the salt and pepper type of chromatin, polydifferentiated squamous cell carcinoma, and Beckett's lymphoma because of that starry sky kind of appearance and that hyperchromatic nucleus that we see here. And then also the cells all look monotonous. Next. So a clinical impact for this case, usually the surgeons, the ONG team, it depends on the staging. If less than 2A, then they do C-section at 37 weeks with hysterectomy, with hysterectomy followed by chemo. But if staging is more than or equal to 2A, they allow for the baby to be delivered, followed by radiation therapy. But in this case, they might, because when they went in, they saw it was quite extensive. So they might just allow for delivery and then we'll follow on with chemo. I think that's all. So discussion was mainly the morphological features that point to the origin on H&E. I know that's quite difficult, but I think thank you to the mentors who've pointed out the salt and pepper type nuclear chromatin and the nuclear molding and that. And also, should we give an opinion? We have our differentials there, but should we give an opinion on what we prefer? Yeah. Thank you. That's all for the first case.
So who's going to lead the discussion?
I volunteered to this time, but I'm very happy for everybody else to jump in because this is really difficult. Thank you very much, Jackie. That is a great presentation of a difficult case, particularly if you don't have IHCs. Like we've actually just been looking at it here in the lab. I looked at it with some other pathologists, and we normally just add another 10 stains to this.
Okay.
So that is so I feel the difficulty. Do you actually have any idea if she has got a positive HPV status?
I'll check with the ONG team on that. But I don't think so because we haven't rolled out our HPV screening yet. So I don't think we would have that. Yeah.
Because that would sort of help knock. I do know that having looking at that differential, I did show it to our PEDS people here, and morphologically they were against lymphoma because it's a bit too cohesive. So again, it's really hard to tell from the photos versus what you're seeing on the slide.
Yes.
But that would sort of been the feedback from our PEDS people here.
Yeah.
So yeah, the other question I did want to have is, do you have any IHCs running at the moment apart from ER, apart from the breast markers?
No, I think we have, but we must have run out of our P16 because I was going to do P16 on that one for HPV.
Yeah. Yep. That would help too.
Yes.
Okay. Well,
so if we
Jacqueline, what about serum? Do you have any blood markers, any LDH or any markers like that?
Yes, we can do that. LDH alpha fetoprotein, we can do that.
Okay.
But LDH in particular, is that what you recommend?
It can be high in a few things, but I think it should definitely be high in small cell.
Okay.
What do you others think? Do you use LDH much? No.
I've seen it used in the setting of lymphoma and dysgerminoma. It can be elevated as well. Wasn't aware of small cell.
Probably not helpful then.
But yeah. I think something to remember with small cell neuroendocrine carcinoma is we can make the diagnosis on morphology alone if the morphology is classical. We don't need immunohistochemistry because sometimes the immunos are negative, the neuroendocrine markers, the keratins can be negative. So I think if we're confident that it's a small cell neuroendocrine carcinoma on morphology, you can probably tell the clinicians that.
Okay.
And I think a neuroendocrine carcinoma is top of the list over ahead of lymphoma. It's corded and trabecular. I
Yeah.
think if it was lymphoma, it would be diffuse sheets.
Yeah.
Yeah. It's unlikely to be something that's an endometrial primary, but given her age and given the clinical impression,
Yeah.
I guess it's just a question, is there something we're not thinking of, that we need to put ahead of a neuroendocrine carcinoma?
Is P16 also positive in neuroendocrine carcinoma?
Yeah, it's diffusely positive in a lot of high-grade malignancies, and it can be diffusely positive in a neuroendocrine carcinoma, but most of these in the cervix are HPV driven.
Okay.
So it's not going to really have any discriminatory value other than confirm what we already suspect morphologically. So its positivity would be helpful, but it's not going to be a diagnostic, I guess.
Okay.
And it
Yeah.
shouldn't hold up the management, We need to crack on and make decisions about this lady.
And I assume that your clinicians would give different chemotherapy if you called it a neuroendocrine carcinoma versus a poorly diffed adeno.
I'm not sure about that.
Yeah, because if it doesn't, if she's high stage and it's inoperable and they're going to give chemotherapy, I guess with curative intent, if that's achievable, I guess it'll be good to know if the nature of that chemo would change based on that distinction morphologically, and whether radiation therapy will be given as well.
Yeah.
I think the problem, Karen, is that if it did, how would you separate them on what you have, apart from a mucin stain? But it's going to be so low reliability.
You'd have to make a call on morphology, I think.
Yeah. So you're still back at that point. Certainly, we've had slides come in from the Pacific with HPV-driven tumours, and they are incredibly ugly. And with a panel of IHCs, we can't get to the bottom of it.
Yeah.
So I have a respect for how ugly the carcinomas can look as well. But it is, if you, so that does make it hard, very, very hard.
Okay.
Along that line, I think there are certainly some circulating HPV types that are different in different geographies and that do have this propensity to produce ugly, high-grade, or even mixed neuroendocrine adenocarcinoma type of lesions in the cervix. And in fact, in my experience, I've seen more of those coming out of Vietnam or Asia than I have domestically in the US. So I think that's what I would certainly lean towards, is this being an HPV-driven neuroendocrine carcinoma. I think the molding, the nuclear molding and the nuclear features are very helpful in excluding lymphoma, and they're certainly not the sort of thing I usually associate with conventional poorly differentiated adenocarcinomas of the endocervix.
Okay.
I think there's a lot of apoptotic stuff as well as the mitotic figures, and I think that's quite helpful. That points me more towards a small cell rather than a standard endocervical adenocarcinoma. Whether that's valid or not, I don't know, but just an observation. Jacqueline, how big is it? What's the clinical staging?
I think the clinical staging is, they said from yesterday, they said that they were going to allow for the delivery to take place, which means that the clinical staging must be more than 2A.
Right. So do you have CT? Has she had some imaging?
We have CT, but I didn't check for that.
Okay. All right. Because it really all does come down to the stage, doesn't it? So they're planning to give chemotherapy and then deliver the baby, or deliver the baby and then
first and then give chemo.
Okay.
When are
And so
they?
she's still 35 weeks, is she? Or is she now a little bit further along?
36, probably 36 now.
Okay.
So when can they deliver the baby? What's the earliest you can deliver
For
that?
us, the earliest would be around 30, 37, 38 because of this, we don't have NICU. We have special care nursery, but not NICU, so we can't be able to deliver it any earlier. Yes.
And will
So
that be a Caesar rather than
Pardon?
a Caesar, cesarean section?
So they said they've just probably induce
Okay.
the yeah, because of when they went in, they saw that it has it's probably 2A already. It's the poor prognosis. That's why they just allow the baby to induce the labor, and then they will treat the patient. Yeah.
Okay. So is there no contraindication with an obvious tumor? Is a vaginal delivery acceptable in that context?
Yeah, that's what I was thinking. I thought that they
Yeah.
would do that because of the tumor, but they
Yeah,
said
I agree.
Also, she might not dilate very well if she's got
Yeah.
tumor everywhere.
Yeah. I just wonder about rupture
Yeah.
and potential
Yeah.
complications.
Yes.
Especially
Yeah.
because it will be in 2 weeks' time.
Yeah.
Yeah,
Yes.
agree. And if it's small cell, which it looks like, it's fast growing. So it's
Yeah.
bigger.
I will follow up with the case and see how they're managing the patient. So yes.
You
Yeah.
could also, Jacqueline, you could also talk to Arne in Fiji. She's a medical oncologist. She might be able to help with the chemotherapy regime because they sort of see a few more cases than you probably. It sounds very scary and very dangerous, doesn't it? I know we would approach things kind of differently here. She would have full staging, CT, chest, abdo, pelvis, MRI, brain, and then if it's less than a 2, they would probably do a Caesar with a radical hysterectomy. And then more than that, they would actually start chemo with the baby still inside and then get at least some chemo in, which doesn't seem to do the baby any harm, and then deliver later. But I'm not sure if that's an option where you are.
We have someone from ONG in training for oncology, so I can speak to him and see what their plans are for her. Yeah.
Great.
I have another question, kind of theoretical, but stems back to an autopsy I did many, many years ago in a young woman who had been exposed intrapartum to HPV secondary to her mother's infection and papillomatosis and so forth. Does passage through the birth canal in a situation like this where someone has a recognized likely HPV-related lesion put the baby at any kind of increased risk for subsequent HPV-related disease? What do you think?
Is that question to me?
That's a question to the group. I don't know that I have a specific opinion other than just my experience with a patient who developed very extensive laryngeal and pulmonary papillomatosis secondary to exposure to a low-grade HPV on passage through the birth canal.
Certainly be something to be concerned about, I would have thought.
Absolutely. I would be wanting to strenuously avoid any contact between baby and any lesion.
Yeah.
And we're talking about the worst of the worst malignancies here. So why would you, what? Yeah, for me, it just seems really contraindicated to try and deliver vaginally when you've got a high-grade malignancy.
And
And
an
yeah,
infectious risk as well.
and so not just
Yeah, so that
transmission.
might be a helpful argument to use with the clinicians to argue in favor of a cesarean section.
Mm.
And even if it's, too advanced to do the hysterectomy at the same time, at least this way it's more protective for the baby.
Yeah.
Because let's face it, this mother's not going to do very well.
No.
Yeah.
I don't know, would a hysterectomy be also potentially contraindicated in the setting of a neuroendocrine carcinoma?
I spoke to Bryony yesterday about
Yeah.
how she would manage this, and she said if it was small, they would do
They
it.
would reject.
Yeah,
Yeah.
yeah.
Yep.
But it doesn't sound like it's small.
No.
We'll need to, maybe that's something to, Jacqueline, just to check the imaging and have another chat with the ONG doctors.
Sure. Okay, we can go on with the next case.
Okay, I have to switch screens to share this a slightly different way. So here we go.
Okay, the second case is from outstation. It's out of Port Moresby, in the provinces. It's a 17-year-old that presents with a pelvic tumor on the right nexa, and they intraoperatively they found that it also involved the rectum. Next. So usually from outstations, they just send us usually just a tumor because of logistics issues and that. So we just received a small tumor, 40 by 40 by 30, fibrous tissue. It's smooth and shiny surface. The cut section revealed a smooth surface that is shiny, homogeneous, and gray. So microscopically, there's this fibrous, I'm not sure whether it's a capsule but it's just below that. You see the tumor there. That's the capsule, yes. And it's in cords and nest. Next. A lot of necrosis. Again, in probably cords. Next. Similar to the other, it's mainly, they all look monotonous. Next. Next. And then some, they form this kind of lumen, this glandular-like, and some just invade into the stroma. With this, you can see the lymphocytes scattered around there. Next. Next, there's small lymphocytes within the tumor tissue. Next. Okay, with this, you can see that cells are quite large and with the centric nucleus, eosinophilic cytoplasm. Next. And then they seem to form glands. Next. Poorly formed glands again. Next. The nucleus is also kind of like, it's open, like, it's not hyperchromatic, it's, what's the word? It's like open, yeah. Next. Next. And then they form these kind of cells. I thought it was Schiller-Duval bodies, but I might be wrong. Next. It's another one there. Next. And this is mainly just like as glandular structure. Next. There's quite a few, you can see mitosis here as well. Yeah, frequent mitosis. Next. So this one is also pending reporting. I was thinking a yolk sac tumor, stage 3B, because it's already gone and involved the rectum. That's my diff, but after discussion, most of you mentioned dysgeminoma, and I was, for dysgeminoma, I thought that you'd have this, what do they call it? Is it fried egg appearance? So like you see that, so, but I think Rachel sent this article which I read, and it can have different morphology as well. So after reading
yes,
through
that was Karen. Yeah.
Yes. So after reading through that, I probably think it's a dysgeminoma now. Yes. Next.
This is one setting where you could use your LDH marker if you wanted to ask clinicians to do that. Yeah.
So
I would also do an HCG and an AFP as well.
yes,
Great.
HCG, yeah. So
Do you know if
usually
she's had a serum calcium done?
we can do serum calcium as well. Yeah. So it's outstation, so in the province, so they would have to send the sample to us to run. So we can advise them to do that. Yeah. So after the biopsy, what they usually do is just debulking of the tumor. It's multidisciplinary approach with the surgeons and the ONG team, and then they give chemo and radiotherapy. Next. So just points of discussion there, limited clinical information, limited imaging studies, which, because it's from out of the province, special stains, apart from IHCs. And I read that article, it mentioned PAS with and without diastase. And yeah, I think that's all for that case. Thank you.
So it must be a reasonably decent sized tumor left inside, because you've had quite a generous biopsy.
Yes.
Yeah.
Where did the biopsy come from, Jacqueline? How did they get it?
You mean out of province, or?
Did they do a laparotomy, or was that like a?
They did I think they just I haven't checked on that, but I'm just thinking because if they obviously knew that it involved the rectum, so they must have did a lap or something. Yeah.
Right. This is not from within the colon. It's not going all the way through the wall.
No.
It's a pelvic or abdominal biopsy.
It's a pelvic biopsy.
Pelvic biopsy. Thank you.
It was the ONG team that actually did the surgery, and then they probably saw that it involved the rectum, so they just took a biopsy and closed that. Yeah.
So going back up into I agree with Dr. Hahn's email, which I thought was a great summary of a lot of this. But if we go back up into your slides, again, it is a difficult problem without the IHC. I think partly because for me it looks like it's almost quite necrotic, or poorly fixed, which is really classical for dysgerminomas as well. But obviously it makes it really hard to see the morphology. So yeah, coming back up in through here, I agree with what you've said. I agree with what Dr. Hahn said. Certainly, just stopping on these gland bits here, my feeling is to wonder if they're benign glandular elements, which would sort of take them out of the morphology that you're looking at and considering. I wondered if they were like an epithelial inclusion cyst, endosalpingiosis, that kind of thing. Do you guys concur, Rachel, Karen, Dr. Hahn?
Well, that's partly why I was asking where the biopsy was from, because if this biopsy is from the ovary, then they could just be there's a sort of bit of, as you say, endosalpingiosis, or they look benign to me, like benign sort of tubal glandular elements. So
I agree.
you're not quite classical for Schiller-Duval because they should have more like pink in the middle. Yeah, I can't describe it off the top of my head. Sorry, I have to Google a picture of a Schiller-Duval body.
I tried to find the case. It's funny how you don't save these cases, then you can't find them when you need them.
Yeah, I've got a dysgerminoma to show you if you want later after you've finished your
Yeah, no, that's
discussion.
cool. I have one too, but it's not very good.
If this is a yolk sac tumor, it'd have to be the hepatoid variant because it's so solid and eosinophilic. But usually in that entity, you've got more classical other type of yolk sac morphology, and the hepatoid elements are relatively isolated areas in comparison. I like the term decorated donut rather than Schiller-Duval body because I think it's much more descriptive of what you're looking for. And this doesn't make that for me. So, but I wonder also about a Sertoli Leidig tumor that's very poorly differentiated. Those can have little heterologous glandular inclusions as well. So I would include that in the differential considerations, but I'm not sure
And
how
with your comment about the calcium, were you also wondering about a atypical teratoid rhabdoid, or not so
Small cell carcinoma.
large.
Yeah, small cell
Yes.
carcinoma with
Yeah.
hypercalcemia. I mean, I can remember a lot of those kind of tumors in Dr. Scully's files that had geographic necrosis and, very discohesive, poorly defined cells. And I've seen other cases that looked more, granulosa cell that ultimately turned out to be, based on the molecular, turned out to be small cell with hypercalcemia. So I think that's also in the differential in this age group would be ideal for that kind of a presentation.
Yeah, I mean, one of the things is I was going to say a
Sorry.
small biopsy, there's probably a lot of information to come from getting the entire tumor out as well, because that will show whether there's different areas, what else is in there, which we may not be seeing on this.
Yeah.
There was one other morphologic point I was going to raise. Jacqueline, you mentioned some gland formation.
Yes.
Yeah.
Further up, you keep going further up.
Yeah, it was a couple of the earlier, this sort of appearance. And just querying whether they're truly glands or whether we've just got some discohesion in masses or nests of cells that's creating a pseudoglandular appearance. And I think that's a distinction that's also worth interrogating a bit, going to higher power and see if you can actually see a luminal layer of cells that are lining up and that are columnar or cuboidal and truly a glandular epithelial layer, or whether the cells all have the same morphology and they're just discohesive and falling apart a bit centrally. And I think in this case it's probably the latter. I don't know that they're truly glands. And that's something that's worth, because that's obviously a big distinction, isn't it? Germ cell or sex cord stromal versus epithelial. So that's something that's worth kind of going to higher power and just having a closer look at those gland-like areas and teasing out whether you think they're truly glands or a mimic.
Yeah. Okay.
Yeah. Yeah.
That picture there looks remarkably like one of the pictures in the article you sent, Karen,
Yeah.
doesn't it? With that
Yeah,
sort
yeah.
of discohesive falling apart in the middle. And also there does seem to be a smattering of inflammatory cells around the outside, around the nests, which I guess is more of a soft sign towards dysgerminoma.
Yeah, correct. Yep. So I'm just thinking with the immunos you do have, was P16 the only thing you had?
We do we
ER.
have limited ER, PR, and HER2 for the breast cases.
Okay. So there's probably not much to work with there.
No.
The other thing I was going to ask Jacqueline is, do you know, what about the patient? Has she got any symptoms? Does she have any virilization or hirsutism or anything that led her to present?
I'll have to ask the team because the notes just said abdominal pelvic tumor.
Right.
The note, that's just what it said. So I'll have to check with the team. Yes.
Yeah.
Yeah, certainly tumor markers would be really helpful, because if you had, I don't know if you can do AFP there, but beta HCG, if you have those high, that would push you in one direction. Like it's not necessarily diagnostic, but it certainly helps categorize it a wee bit.
Yeah.
And also provide something to follow up in the future.
And throw an inhibin in if you've got that as well.
Yeah.
Yeah. I'm just trying to look up whether juvenile granulosa stains with ER, PR. I'm not familiar with its hormone status. I know obviously adult would, but yeah.
Yeah. So Jacqueline, if she has, if the team decides that she needs a surgery, which seems like she does, she would come to Port Moresby for that?
No, they can do it that the ONG and the surgical team, they would do the debulking of the tumor. They'll remove everything.
Right.
So they won't be waiting for this result to come out. They're just sending the result, but then they will remove everything.
Uh-huh. And what about if the one ovary is normal, would they leave that or would they take that as well?
I'm not sure because I'm not sure about that.
Yeah. It's interesting, isn't it? Because she's only 17, right? And so you think they might want to wait for an answer before they take everything out. But I know it's very hard when you've got such big distances to travel.
And it's also involving the rectum already, so they might consider the staging. Yeah.
Certainly, circling back round to the colorectal versus gynae question, my feeling was that she was extremely young. And certainly you can get colorectal in young people, but just if you're looking at the kind of the stats of it, that's less likely. And combined with that, the morphology would not favor common colorectal types. So I don't know how much access, it may be possible to look up into the rectum if people wanted, if the clinicians wanted to know. I don't know how much that helps because if it's invading through, if you've got normal mucosa, you could feel that it was very unlikely to be primary. But if it invades through, you may not be able to tell. But for me, the morphology doesn't fit with any colorectal type that would be particularly common, particularly in a 17-year-old, given that you've got all of the germ cells and the other type entities in the background there.
I can remove that from the diffs.
We always IHC everything, so we never have to make these calls on H&E. So it's quite a challenge. Yeah.
I can remove it from the diffs, the moderate to polydifferentiated adeno colorectal carcinoma. I can remove that. Yeah.
Yeah, I would.
In agreement. Yeah.
Yeah, you've got a tough job, Jacqueline.
Well, I think you're right. The tough distinction here is distinguishing between sex-cord stromal and germ cell tumor. But if they can do some serum markers, that may help you greatly in that differential, along with some of the clinical parameters, and then debulking her and so forth would make great sense.
Yeah. And it would be good to get the serum markers before they debulk her so that the tumor is still in situ to give us information. That would be great. Yeah. Very.
Thank you.
Do you want to see? I could show you my case if you like.
Did you say you had a good version of a dysgerminoma, Rachel?
Well, I think there's some good aspects to it.
Yeah, good. Because I found one, but it doesn't look very good. So then I'm like, well, I don't know about that.
Well, this is a case I had recently. Sharing now. Okay, can you see that?
Yes.
Great, thank you. So this is a young woman who had some surgery in India, and she was diagnosed as having an ovarian tumor, but no immunomarkers were done. And then she was lost to follow-up, and the differential was a germ cell tumor versus an epithelial tumor. And then she moved to New Zealand and didn't realize she was meant to have follow-up, so presented with ascites and big pelvic masses. And so we've got ultrasound-guided core biopsy of those masses. The other interesting thing is she's got a serum HCG, which is just very slightly elevated, and she's not pregnant, and she has a very quite a high AFP, like in the hundreds. And we got these cores of tissue quite nice cores. They all look the same. So I'll just randomly focus on one of them. And this, I think, is quite helpful with that article of Karen's, because this one's really just quite monotonous and solid. There's a vaguely nested architecture in some of the cores. Oh, sorry, just make you a little bit seasick for a minute. I'll go a little bit closer here. Quite a lot of cytoplasm, and maybe just some very fine little fibrovascular septa around these groups. Not a lot of inflammatory cells. So, this looks quite different to your one, and it can be pretty difficult to tell. And I, of course, had 20 immunostains to throw at it, and it's just beautifully read the textbooks, and all the immunostains are working. So we've got the germ cell markers. This is an OCT4, and every cell is positive. And there are a lot of other markers that we did as well. But interestingly, the AFP was completely negative in my biopsy. So I'm suspicious that actually she's got a mixed germ cell tumor with elements of yolk sac in it that we just haven't found yet. And because this is a very small core biopsy. Well, this one's maybe slightly better with the nested pattern. And all the way through, I couldn't find no glands, no Schiller-Duval bodies, no proper yolk sac elements that I could see in these cores. So I think this bit is all just the pure dysgerminoma, but she probably does have other elements elsewhere. So they're treating her as if she's a mixed germ cell tumor. Over.
Very cool. Thank you. That's actually quite tough because it's quite sort of compressed looking.
Yeah,
it'd be hard work without IHCs.
Well, definitely, and the history of the previous disease and the AFP and the HCG. Yeah. But yes, I mean, it's pretty non-specific, isn't it? Yeah. My heart sank when I looked at it the first time, but all became clear with the immuno. But so, we cheat where we can.
Well, that's what I'm realizing from looking at this. It's amazing how much you have your thing, and then you put your IHCs on, and then you come back to your diagnosis. And I know that the morphology is king, but it's so easy to start with the IHCs and reverse it.
Well, the thing is, we get a bit lazy, don't we? Like our Pacific Island and Vietnamese colleagues have no option but to be good morphologists, whereas we do a quick scan and go, oh, okay, I'm going to use this panel. And then we think about it hard afterwards, whereas you guys have to think about it hard from the very beginning.
Yeah.
Absolutely. Okay. I have two cases that are completely different topics as well. If we've got, what time is it? Oh, 10:46. And they just reflect ones that came across that were raising discussion in our department between people. So the first one is, hang on. How do I share? That's a very good question. Full screen.
Roll your cursor down to the bottom of the screen and a toolbar will pop up.
Share. Oh my gosh, it's having. Gotcha. Okay, cool. So this one is okay. This was intriguing. So she is a female of around in her 30s, I think. Came in as products of conception, and as you can see, we have quite enlarged villi with well-defined cisternae. We have a lot of trophoblast in the background. It's a little bit, some with irregular outlines, trophoblast inclusions, some slightly more fibrotic, but not a particularly dimorphic population. There is elements where you can see which look like the trophoblast, apart from being quite exuberant, is also not polar, so it's sort of sitting, come back up here, around the villus, up the top, and it's quite lace-like. I always find lace-like trophoblast is not something that is, I don't think, particularly specific, but it does tend to make me stop and take a second look. but anything also which runs around the villus. So this specimen, I have to admit, when I first looked at it, I thought was going to be a complete mole, based on the very large villi and the cisternae, and the fact that it looked fairly monotonous. And I'm not sure what you guys think, if that's where you would go to first. That's certainly where I went to. I will skip some of the history because it's perhaps too specific. This is her P57. So we always do a P57 in up front, as part of assessment. I think even when I think it's partial, I do a P57. I don't know if that's a bit overkill. And this is a normal pattern of staining. So it's positive in the cytotrophoblasts, it's positive in the stromal cells. And so that doesn't entirely exclude a complete mole, because you can get complete moles which do have retained P57. They're unusual.
1%.
Yeah, they're there. And
Okay.
I admit that's what I thought this is going to be. However, we have, the bottom line is we have very limited resource here in terms of what we can do with this case in particular, because of very limited tissue. So we didn't have many shots at getting a ploidy. So we've sent it for ploidy, and it is actually triploid. We can't go any further than that because we do not have any more tissue, but we have essentially put it out as a partial mole. So I wondered if it was because it was a partial mole that was very far advanced.
Yeah,
But,
what's the gestation?
I mean, that's we can't go any further than that. I don't know, actually. I don't know that we do know. It's a case. It's not our case. It's from outside, which has come to us for.
Do you have any nucleated reds or placental membranes in there?
We have placental membranes. Actually, most of it's degenerate. We actually have a second specimen, which is also extremely degenerate. I believe we do have, I don't know if I can find them though, nucleated red blood cells, which also pushed us in the partial direction, except for the fact that it is, I'm not sure if I can find them now. There's not a lot, as you can see. And we have no further tests.
Ultrasound's quite handy too. Was there a fetus?
No. Oh, here. There we are. But we do have, yeah. So this would be the other thing that would support a partial mole. It just for me was very unusual because, to be honest, I would have given this complete without that P57 based on morphology. Traditionally, it showed to me that there is definitely an overlap with morphology, which I wasn't as aware of beforehand. So
yeah, I've been caught out a few times, and the trouble with, well, your P57 was beautiful. In fact, I'll write to you later and find out what clone you use, because ours is really annoying because it's a negative stain, right? It's really hard to interpret sometimes.
So I think, I mean, that was more curious than anything else. There's yeah, I mean, unfortunately, there's a bit of other history which is not really possible to show in this context. But and the other one I was going to show also came across the desk as an interesting case. Is completely flicking into a different place, and that is this is another 30-year-old, and this is an ovarian tumor, and actually this is look at the right slide here. So this actually came up as a discussion of at what point do you go from being a benign serous to a serous borderline, and sort of what are the rules around that. And so this came up for discussion. I think we'd called it benign on frozen. And as you can see, it's very bland looking. It's very papillary. It's actually quite hard to see because it's so big. And then you just get these little tufts of proliferative epithelium sitting in the background. Spermatoid calcification there. You know, is this enough? What does 10% mean? Can we give it 10% when you've got so much? You know, it's sort of, for me, it starts to get up into the category of, I'm definitely going to look at this carefully. It's more than just a tiny bit. So we're busy looking at this tumor and thinking about, you know, what point do you push it upwards? Because, you know, the WHO rules, you have your benign serous cystadenoma is allowed up to 10% epithelial proliferation. However, there is a caveat in that, which is nicely put in the current WHO, where it says except on the surface. And so I think we were busy looking at this, deciding, do we have 10% or not, across the whole tumor. And then it came out that actually this whole thing was related to the surface. And so I think I thought I'd just bring along for interest because when we came back up, and if you just look at this at first glance, it's actually quite difficult on the slide to know where you are. And but if you come back out, you get a sense that this is your cortex. So you've got your ovary, your normal ovarian tissue down through here, and you come up and you get the sense that this is that kind of collagenous tissue that's just below the surface. We've lost most of the epithelium across there. One of the things I really like to do with these kind of tumors in the luxury of my practice is to put a calretinin on them, because as soon as you put a calretinin on, you can start to see the architecture of how things relate. And in fact, this, as you come up the top here, looks like mesothelium, that sort of very flattened mesothelium that you can get stretching across an ovary. I do find that morphologically it blurs a wee bit. And then obviously if you've got serous tumor involving the surface of the ovary, you sort of get, you can get both types of epithelium normally. So yes, indeed, this turns out to be the surface running across here. And what that does, that makes it a moot point. Once you have the tumor involving the surface, you can no longer, I guess, you can't call it a benign lesion anymore, because once you have any proliferation which is open to the abdominal cavity, you have risk of spread, which is actually what it turns out once we got further into the case. And so now you see this whole thing with this very minimal proliferation is on the surface. And then you look around further, you realize that actually it has also already spread. So sorry, I'm trying to find my right section here. That's one. So this is elsewhere. If you keep moving around, we now have more surface, again, minimal proliferation, but still present. But what we found, we dug deeper into this case, is that she actually has implants across the surface of the ovary and also up into the abdomen. So this is an auto implant because it's on the surface of the ovary. But you can see that classic thing where it's very shallow. It looks like it could be pulled off. Oops, got a bit of high power there. We've got epithelium that still looks a lot like we do with the borderline tumor, where it starts to sit within the sort of granulation tissue stroma. It almost sort of blurs the epithelium in with the stroma. So although it kind of has this first off look that suggests this could be, metastatic carcinoma, because that's what we often see on the surface of things in the context of reactive stroma. In this case, this is just a non-invasive implant or an auto implant on the surface of the ovary. And then subsequently, we also found similar small things elsewhere in the omentum. So here we are. This is her peritoneal omentum section, I'm not sure. But so elsewhere in the abdomen, again, mesothelium coming around through here, granulation tissue type stroma. We look up closer at that. It's a bit hard to see where the epithelium is sitting here because of also you've got inflammatory response, but you've got it, so it sort of bleeds into the stroma. That's quite classical for implants. And again, sitting up the top here. Oops. Epithelium sitting up the top here, but with mesothelial stroma running around the background. So you know that you're sitting on the surface and not invading. And so I think for me that highlighted the importance of knowing where you are in the ovary. The importance of that rule in the WHO, about 10% only relating to something that's inside, that's intracystic. Yeah, that's the end of that. That's the end of that. But any comments?
What did you end up calling the ovarian tumor? What was the bottom line on the
That's been
tumor?
bottom lined as borderline tumor.
Okay.
Because of the fact with the WHO, because it's on the surface, you can't put it into the borderline, into the benign category.
Okay.
Under their rules, as we read it.
Yep.
Yeah, and to be honest, the spread outside is minimal, but it does support that classification, I think. Why? Any comments?
Oh no, I was just curious. Whether you were going to call it serous cyst adenofibrome with focal proliferation with implants, or whether the implants swayed you toward calling it serous borderline.
I think the implants, but also the fact that because I think if you had, well, actually, to be honest, I would be perhaps hesitant to give implants on a benign lesion. But I think under the rules, that's not allowed when you've got proliferation on the surface. Certainly, that's my read of it. That's my read of the exception in the WHO.
I must admit, I wasn't aware of that, Deb. I haven't been following that rule.
Yeah, likewise.
But also,
New to me.
10% it's so annoying when they try and make things scientific by giving a number, right? 10% of what? Of the whole lesion, but you haven't sampled the whole lesion. 10% of your slides, 10% of the epithelium, 10% of one slide. Like, it's such a vague thing.
That was the
that you
discussion
can-
we had for the tray until we got to realizing it was surface. And the reason is that it is so hard to know. Like, I look at something, I find that the more you worry about something, the bigger it becomes. So we get the same thing with mucinous. It's like, how do you work out your 10%? So I would normally just like clock it and gestalt it to a certain extent. So there's 2 marks for it's really bad, 1 mark for it's a little bit, but how on earth do you quantify 10% of epithelium? Lewis, do you have anything to offer on that? I just look at it, and if it looks
I don't have quantitative
okay.
eyes any better than anybody else. But there is one question I'd like to put out here before we break away here, and that is, I know that this young woman didn't get the benefit of a frozen section evaluation to guide her intraoperative evaluation, but when you get these cases of an ovarian tumor in a young patient, and you're looking at this kind of a differential between granulosa, Sertoli-Leydig, small cell carcinoma, germ cell tumors, and so forth. What are your clues that help you to know kind of what to tell the surgeon at that stage? Is it just serum markers and age? Are there morphologic clues that you rely on mostly, or what's your thoughts?
Macroscopic appearance, I think, is helpful. Discriminating between a sex cord stromal tumor versus a germ cell tumor, there are macroscopic clues that you can utilize in classic cases. But, a macroscopic, the cut potato or fish flesh appearance of a dysgerminoma versus a yellow appearance of a adult granulosa cell tumor or other steroid-producing tumor versus hemorrhagic appearance of choriocarcinoma. So you can take something from the macroscopic appearance, I think, at time of frozen.
And the bloods, because we would always have them available in a young person, heavily weighs you in.
Sorry, what was the first bit, Deb?
I'd say and also the tumor
and the
markers.
bloods. Yeah. We always
it's hard because they're not always
Yeah.
specific, but certainly if the some of them are more than others. I
Yeah.
particularly hate it when they don't tell me if they're up. It's
yeah.
fair to say we have a lot of frozen sections here. We don't get them in young females that frequently, so they are always difficult. And if it's not classic, I will usually try and give a short list to the surgeon with the hope that they can kind of pick a pathway between them in terms of their management.
Yep.
Our surgeons
because realistically,
are really
classic
nice.
is easy, but others are not.
They don't, if it's fertility, if it's a young woman and it's going to relate to fertility involving, do we take the ovaries or not? They never do a frozen section. They always do a 2-stage procedure. So they'll do a cystectomy and or oophorectomy, unilateral oophorectomy, and then give us proper time to look at it and then go back and do full staging. So that it never, if it's ever going to compromise fertility, they don't do frozens. So that's fantastic.
That's a great practice. You're going to get burned if you try to do it in one stage.
Yeah. I think you just have to, I had a case in a young woman in her early 20s where the differential macroscopically and histologically was, and she had an elevated LDH, was large cell lymphoma versus dysgerminoma. And you just can't resolve that on frozen.
No.
And
no, the management could not be more different.
Yeah. And so I was doing that frozen. I just had to say, this is the differential. They did resect it was a large symptomatic ovarian mass. So they did take the tumor, even though I guess for lymphoma, it could have stayed behind. And the only thing I could think to do in the context was to put some in the fridge for flow cytometry, and just put one sort of pilot section on to have come through first thing the next day, to do the stains on.
Mm.
Yeah, so you
I
do
don't.
really get put on the spot when they won't do a two-stage procedure.
Yeah, I think the most important thing about frozens is educating your surgeon in
Yeah.
terms of because there are so many limitations, and even with the straightforward things, older female epithelial tumors, it's easy to be wrong. So
We have so many examples. We're doing an audit at the moment of ovary frozens that were wrong, essentially. Yeah.
Yeah.
We've
The
just had
mucinous
one in the last
ovary,
couple of
the
weeks.
mucinous ovary is the highest
Yeah.
error rate. And again,
Yeah.
our surgeons have pretty much stopped doing them on the large mucinous ovaries, which is good. But we digress because our colleagues, we have done a frozen section in Suva. Last time I was there, it turned out to be TB. So we don't do many frozen sections in the Pacific, do we?
Well, I
yeah.
think we do some in Vietnam, and that's part of why I raised the question, because I think this is still one of the problem areas in pathology, and especially in GYN pathology, is managing the intraoperative patient of an ovarian tumor that's not amenable usually to biopsy, and may need to, make a decision in terms of staging or, fertility, as you've said, and so forth. So I think that's a good practice in such settings where you don't have a lot of experience, or you don't have definitive evidence one way or the other, is to make sure that you aren't burning your bridge for future choices. And the small added cost of a second procedure is far better than making the wrong decision and sacrificing someone's fertility needlessly.
I agree. I think the other thing we did do a lot of when I was at Mater, I do perhaps less than here, is do smears. So smears can be useful. The problem is you have to be comfortable with cytology, particularly if you're going to cord. I do find that's very useful in the context of some tumors for looking at the nuclear detail, particularly if a frozen's not great, and using it as an adjunct. I don't know about replacing a frozen if I didn't have access to a frozen section because my cytology is not that good. Someone who did a lot of routine cytology might be better at that. But where you don't have access, like most of the places I go don't have access to frozen section because they don't have a frozen microtome. So,
but that's a great
cytology
way
would
to
be a
learn.
potential way around that.
That's a great way to learn cytology, is to practice doing imprints on fresh samples, so that when you do need it in a pinch, you have a little bit more experience on which to make a judgment. Yeah, I did that all during my training. Was touch imprint this or touch imprint that, and it really helped greatly.
Who's up next time? Do we have a presenter? I think it's written down somewhere.
Let me see who's on the schedule here.
Is our schedule changed? Because